California, and child neurology training at CHOC and UC Irvine. She also completed a subspecialty fellowship in pediatric epilepsy at CHOC and UC Irvine. She is a member of the American Epilepsy Society, the American Academy of Neurology, and the Orange County Medical Association. Her research interests include understanding epileptic disorders such as infantile spasms and Lennox-Gastaut syndrome, investigating different treatment options in patients with refractory epilepsy, and quality of life in patients with epilepsy. And it is my pleasure to present Dr. Steenari.
Great, thank you so much. Let me see, is that good? Big screen with neurology and Sturge-Weber.
Perfect.
Can you see that? Excellent, perfect. So thank you for having me here today. Let's see, so quickly we'll talk about all neuro complications with patients with Sturge-Weber in 20 minutes. So be ready for rock and roll. You know, I know you've heard about this probably in the beginning of every lecture, what causes Sturge-Weber and when. But why I wanted to bring it up in the beginning is it is actually important when the mutation in this gene happens during the embryonic development. So after conception, when the embryo is developing, if the mutation happens in the at the time when there's still one part of the ball or the vesicle that creates the whole brain, both hemispheres and the eyes and the skin on the face, we can have patients with bilateral Sturge-Weber changes. If the mutation happens at the time where there's already division to the left and the right, but the area where the eye is developing from, we can see, and the skin is developing from, we can see, you know, same side changes on the brain and skin and eye, and so forth, and that kind of makes a difference on how patients have symptoms from their Sturge-Weber. The most common brain-related symptom from Sturge-Weber is caused by the vascular malformation on the brain, and the location, most common location for the vascular malformation is actually on the parietal and occipital lobes. This is an MRI of one of my Sturge-Weber patients, showing what we see when we look at patients' MRI. So sometimes we see, let me orient you quickly. So we think about this so that that you're lying on a bed, your head is facing away from us and your feet are towards us, and then we look from the bottom, from the neck up. So what happens, actually, your bottom of the head is here, your nose and eyeballs are towards the top, but then the right side of the brain is on the left side of the picture. So this is the back side of the head and this is the front side of the head. So there is a atrophy on the brain, on the cortex, on the occipital head region on the left on this particular patient. So the beautiful sulci and cortex structures that are normal on this particular patient on the right, there's atrophy on the left. And then when we look at head CT, we see calcifications. That's quite classic for patients with Sturge-Weber. All right, so what do we see as a pediatric neurologist? What are some symptoms that I see on my patients who have Sturge-Weber? Most common are seizures. Some of our patients have stroke-like episodes. Headaches are very common and often the most bothersome symptom, actually. And then developmental delays are also quite frequent. So when we see, I'm sorry if I talk about kids only, just because I'm a peds neurologist. But when I see a child first time, in my clinic with Sturge-Weber skin lesion. I'm starting to get more concerned if the lesion is bilateral, so both sides on the face, forehead involvement, and kind of that frontal hemi-midline involvement. I have another picture here, a drawing that shows kind of different high risk versus low risk of brain involvement with patients with Sturge-Weber. So kind of bilateral forehead or bilateral face, very high risk, hemi face, midline, and forehead, highest risk for pediatric neurologists to get excited. So why something that we often see on the skin, vascular malformation, can cause an issue in the brain? As I mentioned in the beginning, the brain, skin, and eye evolution during when the embryo is dividing and creating this beautiful body of a patient, and part of it, there's a mutation on those genes that are associated with the development of some brain structures, and then also vasculature, and that connection there. So when we have an abnormal vasculature on the surface of the brain, that causes slowly kind of chronic brain injury, loss of well oxygenated blood, and then kind of slow gliosis, ischemia and gliosis, and brain that is not getting good nutrition, so is having low oxygen and low nutrition, is really angry and irritated, and irritated brain often causes seizures. So we don't know exactly how the Sturge-Weber vascular malformation causes seizures, but it's thought that it's that insufficient oxygen and the vascular structure that then causes the chronic atrophy of the brain tissue, and ischemia, and also some authors think that the calcifications that are collected there, they by themselves are also very irritable to the brain cortex, and then can cause seizures. We also know that in other syndromes, like patients who have strokes, there's higher risk for seizures. So there's something in the brain when the brain is when the brain has lack of oxygen, and ischemic changes can increase the risk for seizures. So why do we care? Why is an epilepsy doctor excited about patients with vascular malformations and seizures? So seizures are very common. Epilepsy is really common on patients with Sturge-Weber. So majority of the patients, 75 to 80% of the patients with Sturge-Weber syndrome, and I mean patients who also have involvement on the brain, have seizures. And epilepsy is very common, even if the vascular malformation is on one hemisphere, but especially if you have bilateral disease, and you have bilateral changes on your brain, almost all of the patients have seizures. So maybe you ask, well, I'm an adult with Sturge-Weber, so what is the age when the seizures happen? Majority of the patients actually present under first year of life. So if you're kind of, a 37-year-old, it's very it is still a possibility, but it's much less of a risk. So the highest chance is within the first year of life. So what do these seizures typically look like? Like how should we describe these seizures? They're very common, commonly with motor symptoms, motor clonic seizures. So the one-sided rhythmic jerking of the arm, face, or leg. And what's quite typical for patients with Sturge-Weber is the seizures are when they start, they cluster. Some kids or some patients have short seizures, but they tend to cluster. They have several seizures in a row, or one seizure lasts for a very, very long time. It's not uncommon that my patients with Sturge-Weber have 30-minute long focal seizures, and that's what we call a status epilepticus. So oftentimes when we haven't found a good seizure control yet, you know, the families use a lot of rescue medications because the seizures tend to last for a long time, or they tend to cluster, and that cluster just keeps on going. And why do we care about that? We know that if we have a patient who have a particular region of the brain that's associated with Sturge-Weber findings, who doesn't have seizures, and then we have a patient who have in the same region, same extent of the brain changes, but has seizures, the developmental outcome is worse on a patient who has seizures and epilepsy. So we try to be very, very aggressive controlling these seizures to provide the best outcome for these kids for the future. Let's see. So then going to stroke-like episodes, and what does that mean? There is a neurological symptom that lasts from 10 minutes to half an hour to an hour, and sometimes even longer than a day. I think the most common, what I've seen on my patients, is one-sided weakness. It can be facial droop. It can be weakness on the arm. Like the easiest way of testing, we ask the patients to lift arms up, and either they are not able to increase the other arm at the same level, or not at all. Sometimes it's quite even flaccid. And what's thought to be causing these is either sometimes they're triggered by minor head injury. So some of my parents tell me, like, you know what, Johnny was running on the park and something happened. He hit the head on a slide pole, and now he has this right-sided weakness. Did he have a stroke? Should we image him? And sometimes it's actually triggered by a seizure. And sometimes unexplained periods of weakness we found that can be caused by what we call subclinical seizures. So the brain, the irritable brain structure is having a seizure, but outside we can't tell, and only when we put EEG leads on and measure the electrical brain activity, we see continuous or very frequent seizures, and as a result of that we can see these stroke-like symptoms. So I typically do get an EEG on my little patients if there's an unexplained periods of weakness, even if we haven't seen any clinical seizures. Sturge-Weber brain lesions, they don't typically bleed, so we don't need to do a HIT CT every time after a brain injury. But I'll talk about imaging recommendations a little bit more later down the line. So getting to the headaches. So even though to me, as a child neurologist and epilepsy doctor, the seizures and getting those seizures under control is one of my main goals. Actually, headaches are what oftentimes the patients feel are the most troublesome, and oftentimes they're migraine type of headaches, and they're often quite challenging. Many patients need to stay out from school or miss days at work, so it causes a lot of problems. There is no association with how big of an area in the brain is involved. There's no association if it's bilateral versus one-sided brain involvement. There's no association, if there's bigger skin lesions or eye involvement either. So even with the small lesion, the headaches can be quite challenging. And sometimes especially with the little ones, like my 6-month-olds or 1-year-olds, it's kind of challenging. They can tell me, "Hey, doc, my head hurts." So sometimes it can be just irritability, periods of crying and not being able to figure out why the kiddos are super irritated all of a sudden. So a headache is one of the possibilities. All right. So how about developmental delays or cognitive challenges? I already mentioned earlier that there's an association of uncontrolled seizures and worse cognitive outcome. But also many patients have hyperactivity, attention deficits, some behavioral issues. Small amount of patients can have autism. But many are totally asymptomatic and do well at regular school. But this is just something that we have to keep in mind to evaluate development and follow development and make sure that we offer support if needed at school. So how do we treat these? How do we treat seizures? We talked about seizures, we talked about stroke-like events, we talked about headaches and delays. So is there anything that we can do to make these symptoms better? So kind of depending on who you read, but there seems to be a consensus of kind of progressing Sturge-Weber syndrome, and that has been linked to kind of recurrent small little thrombosis and ischemic changes on the brain. So most commonly we recommend aspirin to kind of reduce that thrombosis and reduce that venous stasis and make the blood a little bit thinner and easier to go through that abnormal vasculature. Some of the experts in the Sturge-Weber world recommend all the patients treated with aspirin and also anti-seizure medications to delay the onset of seizures, because we know that the later down the path of the patient's journey having Sturge-Weber, the better the developmental outcome. So there are some authors that recommend let's just treat pre-symptomatic patients with anti-seizure medications just to be sure that we are covered and don't have any seizures, to protect that vulnerable brain for developing as best as it can. And that's the aspirin dosing that we typically use. So we can calculate on pediatric side per kilo per day. Migraines or headaches, we use what we typically use for just kind of preventive medications. Some have thought to be a little bit more useful on patients with Sturge-Weber, like a few blood pressure medications. One of them is called propranolol and one is called verapamil. But we also use anti-seizure medications like gabapentin, or Neurontin is the commercial name of that, topiramate, or some authors use valproic acid. And as I mentioned, oftentimes the patients feel like the headaches are worse of their symptoms. Quickly, I know I'm running short of time, but quickly, we can treat seizures not only with anti-seizure medications, but also oftentimes, or not oftentimes, but sometimes when we are failing 2 or more medications, we do surgery and remove that abnormal brain tissue, and then protect the healthy parts of the brain and support the best developmental outcome. So see a neurologist and then epilepsy specialist if one or two anti-seizure medication is not enough. And then quickly, not everybody with skin lesions need an MRI as a child. Only if there's a lesion on a concerning area that I covered, so kind of forehead, big midline, or if there's a neurological symptoms like seizures, developmental delays, or stroke-like events, we recommend MRI, but not everybody needs one, and we don't need routine follow-ups either. And I think that's about it, since I'm running out of time, so we can go to questions.
That was a great talk. And I want you all to know Dr. Steenari came running out of the OR to be able to join us today. So I do want to thank you for doing that. And I'm sorry that you had to be rushed today at all, because I would never want to rush people. So thank you very much for joining us and for that excellent talk.